The following podcast is part of a certified educational activity titled Integrating Biomarker Testing into Alzheimer's Disease Workflows, Tools and Strategies for Specialty Care. Access the entire activity and complete the post-test at peerview.com/VRB860. Downloadable slides and practice aids are also available.
Today, we're going to be talking about integrating biomarker testing into Alzheimer's disease workflows, tools, and strategies for specialty care. My name is Suzanne Schindler, and I'm an associate professor of neurology at Washington University School of Medicine in St. Louis, Missouri. Joining me is one of my colleagues, Dr. Tammy Benzinger, who is a professor of radiology and neurological surgery, also at Washington University School of Medicine. And Dr. Lauren Vandevrede will also be joining us. He's an assistant professor of neurology at the University of California, San Francisco.
Thank you, Suzanne, for the introduction and the opportunity to come and talk about how to integrate biomarkers in the workflow in this new era where we have disease-modifying treatments for Alzheimer's disease for the first time. So just to start off, we're going to talk about what are the benefits of early detection and a biomarker-confirmed diagnosis. And I think a diagnosis is important to patients. Almost every patient that presents with cognitive behavioral symptoms that wants an explanation, both from for themselves and their caregivers and their loved ones to understand exactly what it is that's causing their symptoms. So precision diagnosis as an explanation. Having that diagnosis can enable patients to participate in their planning. The truth of neurodegenerative diseases is we don't often have a choice in the progression, though we can slow the disease down a little bit now, but we have a lot of choice in what the end of the disease will look like. And being able to engage in that conversation with patients while they're still able, I think is very, very important. So the earlier you get the diagnosis, the more useful it is, especially because outside of the treatments that we have, we've always had interventions that we know may be helpful, what we call lifestyle modification. And then, especially in the modern era, in the last couple of years, with the advent of amyloid targeting therapies, the importance of diagnosis, especially early detection when these treatments seem to work a little bit better, is of increasing importance. And I think what I'm noticing, at least in my practice, is that the advent of these treatments is actually driving more people to seek a diagnosis earlier and earlier than they used to. So we have here what I think is a very accurate, concise description of an indication for clinical AD biomarker testing. The most important thing is the patient is coming to you to undergo an evaluation with you, a dementia specialist, and that they have objective evidence of cognitive impairment. They have some symptoms that need an explanation. If AD is on the differential, if Alzheimer's disease is something that you're considering, I think it makes sense that you would want to order an AD biomarker, especially in the MCI stages where there may be more uncertainty about what the precise etiology is. It can give you more certainty that Alzheimer's disease is the cause, which will inform the prognosis of the patient and the likelihood of progression to the later stages of the disease. And then especially if you're thinking about amyloid targeting treatments for Alzheimer's disease. This is, I think, when an AD biomarker should be strongly considered. I think in the modern era, one thing that we have is a wealth of available modalities of testing. We've had CSF testing for perhaps the last decade. In the last couple of years, we now have PET imaging, both being able to detect the amyloid protein and the tau protein. And really, in the last year or so, we've seen a proliferation of new blood tests that allow us to detect the proteins that you see in Alzheimer's disease, like amyloid and tau. One thing I think that presents a challenge is with the proliferation of modalities, dementia specialists may be slightly bewildered by which test to order in which situation for which patient. And in the next couple of slides, we're going to go through each of these different modalities in detail and understand the drawbacks, the benefits, and when you would potentially order them. So we'll start with CSF testing, which I think makes sense because this has been the one that's been available for the longest. And there's appropriate use guidelines. They were published in 2018, but they talk about context of use or clinical scenarios in which experts would think this test would be appropriate to use in a patient to achieve that precision diagnosis. And starting in people that have subjective cognitive decline, this is impairment that's noticeable to the patient, but maybe not detectable on testing yet. But this person may be at increased risk for Alzheimer's disease. We certainly would be appropriate in that case. Patients who have MCI that is persistent, progressing, or unexplained You want to know if Alzheimer's disease is the cause. If they have symptoms that suggest possible AD, and this is atypical presentations, language presentations, patients with comorbidities like vascular disease, people with atypical clinical courses, patients with MCI or dementia with an early age of onset, early onset Alzheimer's disease, where the symptoms start before the age of 65, or even patients that have a typical presentation of Alzheimer's disease, amnestic, with an onset over the age of 65 years old, where you want increased diagnostic certainty or the test is reasonably likely to change your management, this would be considered appropriate use. And certainly in the modern era, I think it's somewhat unequivocal that you would think about CSF biomarker testing for a patient that was potentially eligible for treatment with an amyloid targeting therapy. So when would you consider using the new amyloid and tau PET radio tracers? I say new, even though amyloid PET has been around for 20 years. It's been only recently in the last year that we've had a coverage determination for amyloid PET, making it more clinically available for people to order. And then very recently, within the last month, there's been a refresh or an update of the appropriate use recommendations for amyloid tau PET. I would recommend going through and reading them in detail because they detail all the different clinical scenarios in which you would consider ordering an AD biomarker and discuss whether it would be supported as an appropriate use or maybe it would be relatively discouraged. But if you look at the appropriate use criteria, if you look at the context of use on the slide here, you'll see that they do largely parallel the CSF testing as well. Patients with SCI with high risk, with MCI where there's progression, in atypical and typical forms of Alzheimer's disease. To go through all the different modalities of the biomarkers, I think that there's pluses and minuses of each one of them between PET and CSF and plasma. But a PET scan gives you spatial distribution, the amount of pathology. We do have a history of understanding amyloid PET. PET has been used in medicine for a long time for other reasons. Medicare now covers it. I think these are some of the strong advantages. The limitations of PET are that it can be quite costly. Amyloid PET, $3,000, tau PET in the order of $10,000. Coverage is unclear for tau PET, more clear for amyloid PET, but other insurances and other indications can become more uncertain. But I think having these radio tracers available, having these modalities, I think can be the real challenge. Not every center has access to the cyclotrons that can make the radio tracers and be able to get them quick enough. So there is limited capacity and availability. CSF testing has long been used for precision diagnosis of Alzheimer's disease. There's multiple FDA-approved tests with high diagnostic performance. It may turn positive slightly before amyloid PET. Useful if other diagnoses other than Alzheimer's disease are on your differential, like synucleinopathies. There's tests in the CSF. Maybe you can test for multiple proteins at once with cerebrospinal fluid testing. But the drawbacks, I think, are also straightforward, is that there's a stigma around lumbar puncture. Patients generally do not prefer it. Providers sometimes are disincentivized to do it because of reimbursement. There can be post-LP complications, though these are fairly mild. And it doesn't give you the information about the regional distribution of AD pathology. And then there's the blood tests that have become available over the last couple of years. And I would say, in general, patients prefer blood test over CSF tests, doing a blood draw much easier than doing a CSF draw. This is more rapidly scalable, more likely to be uh, uh, relatively affordable, coverable. But these tests, as it exists right now, exist in sort of a nebulous space where we don't have FDA approval, we don't have clear coverage determinations. Suzanne, I was curious about what you've been observing in terms of relative usage of these different biomarkers in your practice and at your center.
So, a few years ago, we really only did CSF testing because high accuracy blood tests weren't available, they didn't exist, and also because amyloid PET scans weren't reimbursed by insurance. But things have really changed. High accuracy blood tests became available, and we started using those really a couple years ago and have increasingly felt comfortable using them because of additional validation studies. But then what happened about a year ago is that CMS started reimbursing for amyloid PET scans. And that has really changed things because now they're substantially cheaper in many cases than a high accuracy blood test. So we're now doing a lot of amyloid PET scans. I think that this year we may see the approval of some of these blood tests and also the reimbursement of them. And if that happens, I think things will shift again, where we will start using blood tests as our dominant modality of testing. Because if you ask a patient whether they want a lumbar puncture, a blood draw, which they're usually already getting anyway, or a PET scan, they will almost always go for the blood test.
Tammy, what have you seen in terms of the PET scans being ordered?
Right, yeah, so as Suzanne mentioned, we went from maybe 4 amyloid PET scans a year to about 40 a month, after the CMS reimbursement changes in 2024. And I really do hope for those of you who are just starting out in this line of therapy or starting out in your practice, that are watching this webinar, think carefully about capacity and workflows and ways to accommodate that, because most of us in radiology are already working at capacity, and so um, even though it's an easy test to perform, it might be hard to schedule and get it put together, but I think we probably need to strategically think about limiting the PET capacity for those cases where there is something ambiguous in the clinical presentation or in the blood test, or they've been on therapy, and there's a question about the response that's happening, because they really do answer different questions.
Yes, and the one other issue that we're still kind of grappling with is how helpful it is to have an amyloid PET scan at baseline for patients who are receiving amyloid targeted treatments. Uh, I don't know if we really need a baseline amyloid PET scan. Basically, we treat people if they're positive, and it doesn't matter whether their amyloid PET centiloid is 60 or 120. But but if we're thinking about stopping treatment at some point, is it helpful to know what the initial amyloid PET scan value was? Tammy, do you have thoughts about this?
I really think that ideally the amyloid and the tau PET scans are at baseline reserved for those more complicated cases, where there's a diagnostic dilemma. Um, I do think that if you have somebody that's been on therapy 18 or 24 months and, they're requesting to go off therapy, I think an amyloid PET with quantification with the centiloid can be really helpful. So if you get the amyloid PET scan at that point and it's negative, your centiloids are, below 30 or below 20, I don't think it matters what the original PET scan showed. You've got a measure that says there's not significant amyloid plaque in the brain right now, and I think that can be helpful to guide that therapy. I don't think you need the baseline if you've cleared it at the end.
Okay, that was a great discussion. Now we'll move into all the blood-based biomarkers.
All right. So, what is the state of Alzheimer's disease blood biomarker tests used for clinical care? Well, I think the first point is that clinicians and patients are going to need blood tests in this new era of treatment. Of course, we have at least two drugs that are approved now that are in clinical use. And to have access to these treatments, you must have Alzheimer's disease biomarker testing. This is required. So, biomarker testing is really an access issue that limits our patients' abilities to have access to treatments. Um, we think that these blood biomarker tests are really the only modality that will enable the kinds of volume that we will need for these tests, which is probably in the order of hundreds of thousands of millions of tests per year globally. That's not something that we could achieve with CSF tests or PET scans. So we really are going to have to use these blood tests. Fortunately, we do have tests that work well. And of course, these tests are less invasive, more accessible, potentially less expensive than the CSF biomarkers or PET scans. We see increasingly in our clinical practice that clinicians are using these. I have patients showing up in my clinic who have blood test results already because their primary care doc ordered them. And I've been seeing this more and more. So these tests exist, they're being ordered. and we expect they will be really critically important as we move forward in the field. There are still some barriers to these tests, though, that the biggest one is they're not reimbursed by insurance right now, or they're inconsistently reimbursed. That's why I'm not ordering them more frequently. Another issue is that there's knowledge gaps in how to use these tests and interpret the results. As I mentioned, there are highly accurate Alzheimer's disease blood tests that are clinically available now. One of these tests was published in this paper in Nature Medicine, where it was compared in a head to head way with two FDA approved CSF tests. And it was just as accurate as those FDA approved CSF tests in classifying amyloid PET status. This test was also evaluated in a large cohort in Sweden, and they found that primary care docs were only correct about 60% of the time when they were considering whether someone had amyloid pathology or not. Specialists like me were only a little bit better, about 70%, if they didn't use biomarkers. So, clinical criteria are not enough to tell us whether someone with cognitive impairment has this Alzheimer's disease pathology. We have to use biomarkers. Fortunately, they also found that these blood tests perform very accurately in determining the presence of this Alzheimer's disease pathology. And this was despite the cohorts they were studying having quite a high rate of medical comorbidities. We have also done head to head studies of a number of clinically available blood tests. And what we have found is that tests that include p-tau 217 are the most accurate. And these plots are showing classification accuracy for amyloid PET status, early tau PET status, cortical thickness status, and cognitive impairment status. And we see that these p-tau 217 tests, regardless of the specific assay, are really always performing the best. So, at least in my clinical practice, I would only want to use tests that include p-tau 217 because I know that other tests, including those for just A beta 42 to 40, which are shown here in blue, they just don't perform as well. And so, you're going to end up misdiagnosing individuals if that's the test that you're using. We also have spent a lot of time thinking about the populations that you would uh, study or perform clinical biomarker testing in. These are target product profiles for triaging and confirmatory blood biomarker tests, both in primary and secondary care. So there's two major ways that we would use the test. One is we just perform the test, and that is our answer about whether they're biomarker positive or not. That's called confirmation. To do that, we know that you need to have a very accurate test. And in fact, we think that the test should be just as accurate as FDA approved CSF tests, which is a sensitivity and a specificity of about 90% for amyloid PET status. However, there's a second way that you could use this test, and that is in a triaging capacity. And what that means is you still want a highly sensitive test so that you don't miss people. So it needs to have a sensitivity of at least 90%. But the way you're using that test is if they test positive, you follow it up with either a CSF test or an amyloid PET scan or a higher accuracy blood test. So if you're using the blood test in a triaging capacity where you're planning to follow positive results with a second test, then you can get away with a lower specificity. So 75 to 85%, depending on the capacity for follow up testing. And that's because you will identify the false positive results with the second test. Now, how do we interpret these results, both really in secondary care and also in primary care? And what this requires is integrating the results of the blood test with the clinical picture. The way that a variety of specialties, medical specialties, deal with this is by incorporating something called a pretest probability. The idea is that if you start off with someone who has a high likelihood of amyloid pathology, so imagine someone who's 75 years old, 80 years old, who has a very typical 80 dementia syndrome, they are very likely to be amyloid positive. And we know this from a large number of studies. And the prevalence of amyloid pathology in a patient who looked like that would probably be about 80% or higher. And in a patient like that, we would expect that a positive result would correlate with a very high uh, predictive value. So 97% or higher, depending on the characteristics of the test. In this case, we're talking about the confirmatory test with the sensitivity and specificity of 90%. Um, on the other hand, if you have a patient who is less likely to have amyloid pathology, so maybe someone who's younger and has subjective cognitive symptoms, but they do not have a clear cut dementia syndrome. Again, the same exact test, but if you have a positive result in that patient, there's a significant likelihood that the test could be wrong. So the positive predictive value is only 69%. So that means you're going to have about 31% of those individuals who are false positives. So this test, though, could be very helpful in ruling people out. So if you get a negative result in that patient who's less likely to have amyloid pathology, then that negative result is going to be correct about 97% of the time. The point is that if you have a patient who is, before you even do the test, likely to be positive and the result is positive, then you can have high confidence in that results, that they actually do have amyloid in their brain. However, if you have a patient who is relatively unlikely to have amyloid pathology and the result is negative, you can rule them out. They are unlikely to have it. But if they have a positive result, you still have to have some suspicion that that result could be wrong. So, really, you have to treat the patient and not the test. And if the test does not line up with your diagnostic suspicions, it's best to do further assessment, potentially with another Alzheimer's disease biomarker test or with other types of testing. So, another issue to consider is that Alzheimer's disease is a continuous process. So people aren't just positive or negative, there's a spectrum of disease. And the biomarkers reflect that. And I've talked about how we want the test to be at least 90% accurate. Why not 100% accurate? This is really because about 10% of people fall in this gray zone. So, how do we deal with these patients and how do we increase our diagnostic accuracy? So, the way that we have found to do this is to not just have one cutoff, but to have two cutoffs. And so we set a low threshold, a low cutoff, so that when someone's negative, we have very high certainty that they're negative, clearly negative individuals. And we set a high cutoff so that if they're positive, they're above that cutoff, there's really no doubt that they're positive. And then there's some people in the middle in this intermediate range, depending on how you set this cutoff. These cutoffs, it's anywhere from 10 to 20% of individuals. Now, people typically don't like getting a borderline result, uncertain results. However, this is very instructive. And when we do this, we find that we can, in some cases, increase our diagnostic accuracy from about 90% to 95%. So increasingly, blood test companies are using this concept to stratify people not into two categories, but actually into three categories. Again, the issue that arises is just that these intermediate folks, what do we do with them? And typically, what I would recommend is if they're a candidate for anti amyloid treatments, I would follow up with a second test, either a CSF test or an amyloid PET scan. If they are not candidates for treatment, then I think it may be reasonable to follow up in a year with a second test of really any modality. Another issue that comes up with blood tests is that certain medical comorbidities have been shown to affect the levels. And this is true for a variety of analytes, including both p-tau 181 and p-tau 217. The uh, comorbidity that seems to have the biggest effect and most consistent effect across studies on these blood biomarker levels is chronic kidney disease. So, the way that I manage this is that most of my patients that I'm seeing have blood tests in their chart, and I look to see whether they have any history of kidney dysfunction. So, a low estimated glomerular filtration rate. And if it's less than 60, then I may consider another biomarker modality like CSF testing or amyloid PET scans. One caveat to this is we know that ratios seem to mitigate the effects of some of these medical comorbidities. So things like percent p-tau 217 or the A beta 42 to 40 ratio seem to be less affected by these medical comorbidities. Um, However, this is just something that we need to consider when we're thinking about which modality is most appropriate to use in different patients. I think it's important to emphasize that blood tests are available now. These are blood tests from 5 different companies that I can order on my patients now. And we see patients in our clinic regularly who have had primary care docs order some of these tests. It's important to emphasize that some of these tests are more accurate than others, but all of them are currently in use. The reason they're not being used more often is because insurance is not routinely reimbursing for them. However, we expect that that may change in the not too distant future. And at least one of these tests is currently being reviewed by the FDA for potential approval. Now I'm going to review a case to talk about how you integrate biomarker testing with the rest of the clinical picture. So, this is a patient that I saw who was in her mid 70s who reported that she'd become increasingly forgetful over the last few years. And sometimes she would completely forget the details of telephone conversations and repeat questions during the call. However, she was still able to keep track of her schedule and finances without any difficulties. She wasn't cooking quite as well, and she'd left the stove on a couple times the last year, but she was still doing dishes without difficulty, doing laundry without difficulty, going grocery shopping with herself by herself, and had no difficulty driving. And she'd had no changes in her hygiene or grooming. Her past medical history was significant for depression, anxiety, and chronic back pain. In terms of her medications, she had some significant concerns. She was taking Xanax nightly, high dose gabapentin daily, a high dose muscle relaxant daily. All of these medications are sedating and could potentially impair cognition. She was retired and living with her family, occasionally had an alcoholic beverage, and did not smoke. She had no family history of dementia. The review of systems was significant for snoring and excessive daytime sleepiness. She also reported low mood and had a arm tremor. So keep in mind, this is her history. Just based on this history, what is your differential diagnosis? Ren, what would you think in a patient with a story like this?
I like the presentation because, as you said, it's real world. This is a patient that feels very familiar to me. I would say people coming in their mid 70s with memory complaints. I'm thinking about Alzheimer's disease. That's going to be a part of my differential sort of immediately. But that seemed like memory is one of the more prominent features, and the rapid forgetting with repeat questioning is especially a red flag for me as I'm thinking about the potential etiologies. But as is the case in the real world, you've given me a lot of other potential options and contributors and maybe confounders, including the sedating medications, as you mentioned, the high dose gabapentin, muscle relaxants, the Xanax, the doses of these would be important to understand, and whether the cognitive impairment is around the time of administration of these medicines, if it's more fluctuating or persistent. You mentioned the mood complaints by history and current low mood. We certainly know that mood can affect cognition. Is it sufficient to explain the degree of memory impairment? Oftentimes it needs to be quite profound, like major depressive disorder or current episode, to be sufficient to contribute to cognitive impairment, though certainly can be a contributor as well as anxiety. You mentioned snoring, excessive daytime sleepiness, a common confound and explanation for people that present earlier, I think sometimes, is obstructive sleep apnea as a reason why people can have inattentiveness, poor sleep, and poor cognition. And you kind of mentioned at the very end the arm tremor, which at least raises the question of synucleinopathy like Parkinson's disease.
Great. Well, so uh, I think that different providers may come up with a slightly different ordering of the differential diagnosis, but this is what I was thinking after seeing her. I was most concerned about medication side effects because she really was taking high doses of a number of sedating medications. And I felt quite confident that that was contributing in some way. As you mentioned, sleep apnea was certainly a concern based on her symptoms of snoring and excessive daytime sleepiness. I was also worried about Alzheimer disease, certainly on my list, although I was more concerned about the other potential etiologies. I put Parkinson disease on the list because of the report of arm tremor. And then I also included mood disorder and normal aging. So the next thing that I did is I examined her. And on her examination, she did not have any evidence of Parkinsonism. So that was informative. But she did repeat a question about her medications, and she did have some mild impairment on her episodic memory tasks, which was mild but consistent. So I was concerned about that. As a result, I moved Alzheimer disease up a little bit in my differential diagnosis, and I took Parkinson disease off because I didn't see evidence of Parkinsonism on her examination. The next thing that I did is I sent her for routine blood work, which was all normal, and then I performed a brain MRI. Tammy, what do you think about this brain MRI?
Thanks, Suzanne. So, you know, we're now looking at these brain MRIs in a slightly different way than we have in the past. So, of course, when we get a patient coming in for a memory complaint, we want to run a good dementia protocol. But specifically, a lot of our general brain protocols that are designed for maybe for patient comfort and a quick diagnosis, 10-minute scan aren't necessarily appropriate. In this case, that first image that we're looking at is our susceptibility weighted imaging, which, you can see these black lines over the frontal lobes. That's superficial siderosis. Now, obviously, as a radiologist, we're really worried what is the cause of this bleeding. And in this case, we were able to find something that looked like a cavernoma, which is typically benign in older patients, but can cause bleeding and may have been the cause here. But really important for radiologists to have in the back of their mind the criteria later for therapy. If we have superficial siderosis already on the baseline scan, that puts someone at high risk for future hemorrhages if they happen to go onto an anti-amyloid immunotherapy. So right away, we need to call out, put that in our impression. Second thing is you're showing us the flare exam, and the first thing we're going to be looking for is ischemic change, infarcts, excessive white matter hyperintensities. Those can also be very common alternate explanations for cognitive changes in older patients, which we don't see here. Interestingly, though, you can see that the subarachnoid spaces around those anterior temporal lobes are a little bit prominent, which may suggest a pattern of neurodegeneration or atrophy that could be associated with Alzheimer's disease. Although, of course, an MRI scan doesn't give us the specific biological diagnosis for Alzheimer's. It can only just give us supporting evidence.
Well, thank you so much for going through those scans, Tammy. So, my overall impression after seeing these reads was that she had a cavernoma with superficial siderosis, so would not be a candidate for anti amyloid treatments. But I was also concerned about the pattern of atrophy that you mentioned, and that made me more concerned about Alzheimer disease. Now, one question is, could this cavernoma and superficial siderosis be contributing in some way to her cognitive impairment? And that's a little hard to know, although I would expect that her cavernoma probably would not be leading to any kind of progressive symptoms. I might be expecting more of a stepwise kind of progression of symptoms with that cavernoma, which sometimes has bleeding over multiple cycles. So I did not think her clinical picture was really consistent with cavernoma being the primary etiology of her symptoms, although perhaps it could have somewhat lowered her cognitive reserve. So this scan was unexpected, but overall, the way that I integrated this was that I moved Alzheimer disease up in my differential diagnosis, and I added effects of cavernoma to my differential diagnosis, but lower on the list. The next thing that I did is I sent her for a sleep study, and it showed overall mild obstructive sleep apnea, although it was severe when she was supine in REM sleep. So I did think that this exam was consistent with her having sleep apnea as a contributor to her cognitive impairment. So I moved sleep apnea up in my differential diagnosis. However, I still felt that the primary etiology of her cognitive impairment was likely to be related to medication side effects. So, what I was most interested in was what happened when I weaned her medication. So, I weaned a number of her medications and had her come back and see me in 9 months. And when she came back, she had decreased her gabapentin, stopped her muscle relaxant, and decreased use of her Xanax to once monthly. So these are pretty significant changes. If this really had been the cause of her cognitive impairment, I would have expected her to be much better. She also started CPAP, and initially it was working well, but then she was having difficulty using the machine. And uh, so it the how much that this was really helping was unclear, but her son reported that her memory was continuing to decline, and now she was requiring some help with managing her finances and had been double paying some bills. So she also had some progression on her cognitive testing with slightly worse scores. Overall, what this was suggesting is that her cognitive impairment was getting worse despite the weaning of her medication and despite some attempts at treating her obstructive sleep apnea. So, what is your differential diagnosis now? What do you think, Ren?
Well, I think you've done a good job of addressing the confounders, I think addressing what may be contributing, and often the case that you get increased diagnostic clarity with time. And the progression, I think, raises an eyebrow for me. And I would agree that now that you've addressed the medications and not seen improvement, but in fact seen progression, that would probably decrease. I agree with you completely about the cavernoma, unlikely to be contributing to her cognitive symptoms, but certainly does impact treatments. And the sleep apnea, I think, can always remain as a potential contributor, given it's incompletely treated. But the possibility of Alzheimer's disease with the progression, I think, is probably increased at this point.
And I felt the same way. So, the way that I changed my differential diagnosis was I moved Alzheimer disease up and I moved medication side effects down now that that was at least partly treated. And I talked with the patient and her son more. They wanted a more definitive diagnosis because they were talking about her living situation and making decisions about whether she was going to be continuing to live with her family or perhaps moving somewhere else. So we discussed AD biomarker testing and which modality to use. She had recent blood work demonstrating normal kidney function. She did not want to undergo a lumbar puncture. And at the time that I was seeing her, amyloid PET was not covered by insurance. So it really was not a good option. So we decided to do a blood test. So, Ruan, could you give us a number? What's your pretest probability of Alzheimer's disease in this patient?
I have to say I'm fairly suspicious at this point, given the progression that we've seen, the amnestic presentation. You do have the confounders, which lowers my diagnostic certainty, but I think I would still probably be in the high prior probability range in that 80%. And she would at this point meet diagnostic criteria, at least for a clinical diagnosis. But as we know, that's only maybe about 85% accurate. And assuming that's where I'm falling in line with other dementia specialists, I'd probably put the number about there.
Yes, I agree with those numbers. So we did the blood test, and she had a positive percent p-tau 217 at 10.7%. Notably, normal is less than 4.2%, so she was clearly positive by that measure. However, her A beta 42 to 40 ratio was in the normal range. So it's important to note that the A beta 42 to 40 ratio is quite inferior to p-tau 217 and percent p-tau 217 ratio. This algorithm uh, weights those two measures, both percent p-tau 217 and A beta 42 to 40, and it returned a value of 87. That's on a scale of 0 being very low probability of amyloid pathology and 100 being very high likelihood. So weighting those two measures together, she was an 87, 46 is the cutoff. So she was a clear positive by this blood test, despite the normal A beta 42 to 40. And based on a prior publication, if the pretest probability of amyloid pathology is 50%, someone who has this algorithmic score of 81 to 100 has a 96% chance of having a positive amyloid PET scan. As Ren was telling us, the pretest probability is higher than that, probably 80 to 85%. So what this means is that with this blood test result, her likelihood of being amyloid positive by PET is extremely high, probably 98%, I would guess. And so this is really a clear positive result. So, based on this blood biomarker result, I would say that Alzheimer's disease is extremely high likelihood for causing amyloid pathology.
Now let's talk about the interpretation of PET biomarkers in Alzheimer's disease. So to begin with, we're going to focus on the interpretation of amyloid PET. There are three amyloid PET radiotracers which have approval in the United States: florbetapir, florbetaben, and flutometamol. Each of these have training that is specific to it, which you can go and read about in the FDA labels, as well as it's definitely recommended you go through the online training course or an in-person training course in order to better understand the nuances. In the clinical approach, these are generally reported out as a positive or a negative scan, and these were set up based on pathology reports with either sparse or none amyloid plaques or moderate to frequent amyloid plaques. Now, amyloid is the early pathology for Alzheimer's disease and precedes the dementia. So just because you have amyloid plaques on a scan doesn't mean that you have dementia. Conversely, though, somebody that has symptoms of dementia but has a negative amyloid PET scan means that it's very unlikely that Alzheimer's is the cause of that patient's cognitive impairment. Here's some examples of what negative and positive PET scans look for with each of these tracers. And again, if you go into the FDA labels, you're going to see very specific criteria laid out for that interpretation. Now, negative and positive scans and comparison, a great tip is to look at the difference between the posterior fossa or the cerebellum and the rest of the brain. It's very rare for amyloid plaques to be present in the cerebellum. So when you look at the cerebellum, as in these examples, you should only see the white matter uptake, so that very central signal. On the other hand, when you go into the rest of the brain, so here we're looking at slices of the temporal lobes. What you see on the far left is a negative scan. It only shows the white matter outline. And on the far right is a markedly positive scan where you no longer see that gray matter contrast. And then the middle is an example of an early positive scan, which are usually often some of the most challenging ones that we face. This is just another example, a little bit higher up. Again, clearly negative scan. Number one is that just the white matter uptake. And then the positive scan on the right, number three, is going to show that widely positive scan. And then if you look at number two, it's somewhere in between. So you'll see the frontal lobes and the parietal lobes are positive, but a little bit of the temporal lobe is sparing. That's still considered a positive scan. We also do have the ability to do quantification, and I'm sure if you're in practice right now, you're getting more and more requests for quantification. Most of us are familiar with the SUV, the standardized uptake, or the SUVR, which is when we take a ratio to a control region. This is a way to actually start to get at quantification of positivity. Now, the SUVR, because it's related to that scan that you obtained, is going to be somewhat dependent upon the scanner protocol, the uptake time, and the tracer. On the other hand, there's another tool called the Centiloid scale, which actually harmonizes across those factors. So Centiloid was built based upon a control group of healthy controls, which were set at a Centiloid of 0, and typical Alzheimer's patients, which was set at 100. Centiloid can go above 100 and it can go even below 0. But this is an important way to harmonize if a patient is moving around at your center, maybe between PET scanners or PET tracers, but also between other centers. This is a figure about the Centiloid scale, which was taken from a really nice review article. I recommend you may want to take a look at these articles if you're more interested. What are the limitations of amyloid PET? I think any of you who've looked at these scans will agree with me that a negative scan is easy and a positive scan that's really positive is easy. But whenever you have low signal to noise or motion or attenuation correction artifacts, maybe they've had craniotomy, there's metal in the skull or in the maybe dental artifact, or if they have extensive atrophy, if you don't have a CT or an MRI available, those are all things that can make the interpretation challenging. The last number here, the inter-rater variability, that is, again, something that potentially standardization around a common scale like Centiloid might be able to help with. Now, clinical use for amyloid PETs. So the great news is now we do have FDA-cleared software that can help you with Centiloid. There are multiple vendors that have been approved. This is an example of just one of them, which was called MIM. And this is showing you how that quantification with the Centiloid scaling can be integrated with numbers. They'll give you both an SUVR as well as a Centiloid that you can incorporate. And I highly recommend you do incorporate some of this into your final report because this is what our neurology colleagues are looking for. Now, a really interesting thing I'd like to highlight for you is that in the clinical trials, amyloid PET was one of the ways they demonstrated target engagement. So these are anti-amyloid immunotherapies, and the patients would have a baseline amyloid PET and then a follow-up scan. And in TRAILBLAZER 2, they used Centiloid quantification, and once the amyloid PET was negative, they could actually take the patients off treatment. So in the donanemab prescribing information, there is actually a comment that you could consider stopping dosing based on reduction of amyloid plaques to minimal levels on amyloid PET imaging. This is one of the reasons why you may now be seeing requests for serial amyloid PET scans in some of these patients, and also why you may be receiving requests for quantification with Centiloid, because a simple positive, negative doesn't address the question of whether there's actually been a reduction of the amyloid plaque overall. What about tau PET? So there are two main biological proteinopathies in Alzheimer's disease: amyloid PET, which is the target for those drugs we've been talking about. But the second pathology is tau PET. So, how does tau PET fit into our current clinical paradigm? Well, tau PET has a strong correlation with neuronal injury and is very closely tied to the clinical cognitive phenotypes that patients have. Definitely, if somebody is cognitively impaired and they have a positive tau PET, that can support the diagnosis of Alzheimer's disease. Um, if the tau PET scan is negative, um, you're in a sort of a different space, because it doesn't exclude the presence of tau pathology, but it puts you somewhere else. It suggests that that if they have significant impairment, it may not be Alzheimer's related, because we expect somebody with Alzheimer's dementia to have extensive amyloid and tau pathology. We also know from autopsy studies that there are different staging of tau PET. So what came out of the autopsy studies was the so-called Brock and Brock staging, where the very early tau pathology is just in the mesial temporal lobe or the entorhinal cortex. The intermediate stage spreads out across the inferior temporal lobe into this limbic region. And then finally, the later stages are where you have it involving the primary cortical area. So we call that isocortical or Brock 5, 6. So how do we interpret tau PET? So we're really looking at that neocortical later area. Please don't get distracted by off-target binding that might be choroid plexus, striatum, brainstem nuclei. We're also looking for this spreading, so contiguous areas of pathology rather than small foci. A positive scan is going to be involvement in that posterior lateral temporal lobe, occipital, parietal, and that really does support widespread tau neuropathology. If you see it only in that mesial temporal lobe, um, it doesn't mean there's not neurofibrillary tangles in those regions, but that's not a pattern consistent with Alzheimer's disease. Now, again, off-target binding may be related to melanin, retinal pigment, meninges, and skull. You want to make sure, as with anything, if you're doing quantification, you have a reference region that minimizes off-target binding. And again, the recommendation is to consult the FDA label for fluortaucipir if you're going to be doing this interpretation. Here's just some examples of negative versus positive tau PET scans. And again, the extreme examples are pretty easy, right? Just a blank flat scan versus positivity that's widespread. And here you can see that clear involvement of the medial parietal lobe or precuneus. Now, in 2024, there were new staging criteria for Alzheimer's again released. And we have a lot of evidence that if you have tau pathology, you actually have a greater progression to dementia. So we know this is important for the prognosis of these patients. It can also help you, tau PET can help you distinguish between Alzheimer's and other conditions. So the tau PET tracer that we have in the US right now, which is fluortaucipir, does not have positive uptake in other tauopathies like frontotemporal dementia, dementia with Lewy bodies, et cetera. The specific tracer approved in the US is sensitive only to Alzheimer's type tau pathology. So it really can help in these complicated cases. The other thing that's really fascinating is that where the tau is deposited, where those neurofibrillary tangles are located, correlates to the types of symptoms that patients have. So if you're reading these scans clinically and you see an unusual pattern, it may be helpful to go and take a look. So if you look on panel C, this is that inferior temporal lobe pattern, maybe up in the parietal lobe as well. That would be a very classic amnestic Alzheimer patient with a memory complaint. But if you look on panel A, where you see that strong uptake in the occipital lobe, they may have something called posterior cortical atrophy, and they'll present with um, visual symptoms, actually. They may have partial cortical blindness. So these are patients who will be like unexpectedly having car accidents, for example. So they can't see, but they don't know that they can't see. So this is another role where our nuclear medicine physicians, radiologists, neuroradiologists can actually really help put together that clinical picture of what's happening with the patients. So, in conclusion, I just would like to share with you this recently published appropriate use criteria for amyloid and tau PET. This is a consensus that came out of the Society for Nuclear Medicine and the Alzheimer's Association and is extremely helpful in navigating which type of patient scenario might be appropriate, either for an amyloid PET or a tau PET, and how that comes together. Those of us who are in imaging, nuclear medicine, neuroradiology, et cetera, we're often called upon. Somebody will ask us, well, which test should I get? Or we'll have a test ordered and we don't understand why did they order this. So definitely, of all the things we've reviewed today, this is probably one of the most important things I would recommend to all of you is to just keep this article handy and look at that when these questions are coming in, along with just reminding you that each of these tracers that has an FDA approval has a slightly different reading scale. And so please do pay attention and follow the FDA guidelines for each of them.
Okay, so now we're going to talk about a different case. This is a 77-year-old patient. They're coming in with progressive cognitive deterioration, and importantly, they're being considered for an amyloid targeting treatment. They do have cognitive testing, which has confirmed that their stage of disease is mild cognitive impairment. The pattern is primarily amnestic, though there are multi-domain impairment. They have cognitive testing here, as you can see, that is also consistent and suggestive of mild cognitive impairment, perhaps borderline to mild dementia. There's going to be additional testing that's going to be done. That's now part of our standard workup for patients with amyloid targeting treatment, an MRI, biomarker testing, and an APOE test if the PET scan is positive. We'll move now into some of the results of the imaging.
So, yeah, our first step with these patients is usually a diagnostic MRI, and we want to make sure to run a dementia specific protocol. It's very, very helpful to have a 3D T1 weighted image that we can reconstruct in multiple planes. So, here we can see both axial and coronal views. And that really helps us to look at patterns of atrophy and volume loss. In this case, we've got some prominence of the ventricles, but also of a lot of the subarachnoid spaces, including the Sylvian fissures. And we do have some prominence of the temporal horns that makes us also think about potentially an Alzheimer's component. Many times we'll also run volumetric or quantitative analyses on this. And then another component of this is this very important need to look for sources of hemorrhages, whether these are the siderosis, as we saw in the earlier case, or here the microhemorrhages. And these are just tiny, tiny dots on the image that can be very difficult to identify unless you're running the right protocol. So in this case, we had 3 microhemorrhages, no infarcts. And so from this criteria would definitely be eligible from the MRI perspective to be considered for therapy. But this atrophy pattern is a little bit unusual and may warrant further discussion. In particular, if you look on, again, this value of obtaining that 3D protocol, when we reconstructed in the sagittal plane, you can really see some of these subarachnoid spaces, such as between the parietal and the occipital lobe here. And that may suggest some alteration of CSF dynamics or something that is not typical for just a pure Alzheimer type pathology. We did, get an amyloid PET scan. When we're interpreting these, we think about the tree in the winter versus the tree in the summer. So in this case, we're not seeing that skeleton of the white matter. It's all filled in. So this is consistent with a positive amyloid PET scan. Um, Recommendations are, in 2025, now that we have FDA cleared software for generating centiloids on clinical cases, to also include that quantification when we're working up these patients from the memory clinics, because that may be important to informing their therapy later on. And then handing it back to you, Lauren, it looks like you also did get the ApoE testing.
Yeah, that's right. And now, so that we have the biomarker result, we know that there's a high likelihood of Alzheimer's disease being present. It's now incumbent upon us to incorporate this finding into the clinical case and really understand if that Alzheimer's disease explanatory for the clinical symptomatology. And Suzanne, what would you think about in this case in interpreting that biomarker?
Certainly, the scan shows that they have amyloid pathology in their brain. You can, depending on other clinical factors, wonder whether it's the primary etiology or not. So it would be helpful to know a little bit more about the symptoms and progression of symptoms, just to increase your clinical certainty that it's really Alzheimer's disease pathology that's causing symptoms. So depending on those factors, I would feel more or less certain that Alzheimer's disease pathology is the primary contributor. And then if I felt fairly certain that Alzheimer's was driving their symptoms, then I would consider anti-amyloid treatments. If, however, there were other factors going on that I needed to address first, or that were making me think that Alzheimer's disease pathology was not the primary contributor, then I would not go for anti-amyloid treatment. So it would just depend on those other factors. Um, I am uncertain of what to do with altered CSF dynamics. So that's kind of a question. Of course, in the clinical trials, they didn't assess for that. And so we don't know whether individuals who have altered CSF dynamics would be helped by anti-amyloid treatments or not. That's one issue of treating patients in the real world, is people have things that weren't really assessed in clinical trials. So there's questions about generalizability. Um, but depending on the specific patient scenario, I would consider treatment.
I think I agree with you completely. I think something that I'm finding as we adapt the clinical trial to the real world is that the atypical is typical, and that the cases are often quite complex and require, this Bayesian reasoning that you're describing and integrating all of the clinical features. And these tools are tools to help increase or decrease our diagnostic certainty, and knowing where we can appropriately apply them is, I think, critical. And in cases like this, I think we're finding sometimes that tau PET can be helpful, because if positive, then we can have increased certainty that the brain amyloidosis is in a symptomatic phase, therefore contributory. Though, of course, incorporating that with the known maybe less efficacy with higher levels of tau, I think gives us a little bit of pause in exactly how to interpret that tau PET. But I think there may be a role here for the tau PET as we're thinking about how to integrate that into the evaluation of patients for amyloid targeting treatments.
Well, thank you so much, Tammy and Lauren. So, as you've both talked about, this is a really exciting time where all of these researchers advances that we've made, we're bringing them to patients. And now's a time where we're trying to educate all the individuals who are going to be doing biomarker testing and treating these patients. So, we're very happy to participate in this process and bring this educational opportunity to the broader community. So thank you so much for participating today.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/VRB860.